Hello guys, today's study with me session is about lytic lucent lesions of the bone. This topic is very much important for radiology residents because it's being always tested in Vivas, spotters and in the case discussions as well. Here's the QR code for the Telegram channel. You can scan the QR code and get access to the channel where I post the regular updates of the videos that I'm going to post. Coming to the topic proper of lucent lesions of the bone, there are some 10 to 20 bone lesion names that we need to know on their appearances on the CT and X-ray is very important. Here I have got the compilation of all the images that are important and all the classic examples also. This is important for Viva theory as well as spotters of in radiology practicals. So let us understand this topic and remember it for a longer time with the help of a mnemonic phegnomagic. There is another mnemonic also available on internet which is called as fog machines, but in this video I refer to the first mnemonic of phegnomagic. Now in this abbreviation or the mnemonic, we can expand the terms to get to the lucent lesions that are important for us to learn. This table is from the radiology assistant where they have clearly given few important features of these lucent lesions. I have included one of the tables from radiology assistant here. So the first letter F is indicating fibrous dysplasia and the other word is fibrocortical defect. So fibrocortical defect is also one more lucent lesion that you have to remember with the letter F. And then comes E is eosinophilic granuloma enchondroma, G is giant cell tumor, and one more is geode or subchondral cyst. N is for NOF, that is non-ossifying fibroma, O is osteoblastoma, M for Mets and myeloma, A is aneurysmal bone cyst, S is simple bone cyst or unicameral bone cyst, H is for hyperparathyroidism, that is brown tumor that we study in hyperparathyroidism, I is for infection, infarction and intraosseous lipoma. So we have to remember three entities with the letter I. One is infection, the other one is infarction, that is bone infarction and intraosseous lipoma. C is for chondroblastoma, chondromyxoid fibroma. So the same things are highlighted in the pink table there. G is for giant cell tumor, geode. Geode is nothing but subchondral cyst. And N is for non-ossifying fibroma, osteoblastoma, metastasis myeloma. A is for ABC, aneurysmal bone cyst. S is simple or unicameral bone cyst. H is hyperparathyroidism, Brown's tumor. I is infection, that is osteomyelitis, the infarction, bone infarction and intraosseous lipoma. C is chondroblastoma or chondromyxoid fibroma. So we have three I's and two C. One is chondroblastoma and the other one is chondromyxoid fibroma. So this summarizes the names that we have to know in the topic of lucent lesions of the bone. So whenever we see a lytic or lucent area in the bone, when we are suspecting on the tumor aspect or infection or infarction, we should have all these differentials in our mind. So this one image summarizes more or less all the lucent lesions of the bone. So I'll take you through each image. Now the first image is about first letter F, which is fibrous dysplasia. In the fibrous dysplasia of the femur, we have a famous sign called Shepherd-Crookes sign, right? Shepherd-Crookes deformity. So that bent appearance of the femur is called as Shepherd-Crookes deformity, and the ground glass appearance of the bone is a classic hallmark for the fibrous dysplasia. Ground glass lesion, lytic lesion in the proximal end of the femur with giving Shepherd-Crookes appearance is fibrous dysplasia. Coming to the letter E, which is representing eosinophilic granuloma. All the three images are of eosinophilic granuloma. The first one is representing a lesion in the calvarium with associated soft tissue component. So a lytic lesion in the calvarium with soft tissue component. The second image is showing the lesion in the bones of the arm where it is showing permeative lytic lesion kind of appearance. The third image is showing eosinophilic granuloma in the skull. So one point that you have to remember for eosinophilic granuloma is that it occurs in less than 30 years of age group, which is resembled by the arrow mark in the second image representing the physis or the growth plate. So less than 30 years, there is no fusion of the bone, right? So in less than 30 years, you see eosinophilic granuloma. And next E is about enchondroma. When we talk about enchondroma, there are two most famous syndromes that we need to know. One is Ollier syndrome and the second one is Maffucci syndrome. The first one is starting with letter O. So it has only and only enchondromas. It does not have any soft tissue component in this syndrome. So when you have only enchondromas, so you can see there multiple lytic lesions in the hand, in the short bones, is resembling Ollier's disease or enchondromatosis. Then coming to the second image, where you have multiple lesions in the bone, lytic lesions in the bone, along with the soft tissue component. This soft tissue component is of venous malformation or any kind of malformation. Usually it is hemangioma, venous malformation. So M for malformations or the soft tissue myxomas kind, soft tissue tumor, sorry, it is hemangioma, and the lytic lesions that are described there with the soft tissue component. When you see near the thumb, you have those phlebolids, hyperdense punctate appearance. Those are resembling the phlebolids in the hemangiomas, which are associated with Maffucci syndrome. So enchondromas, we have to remember two syndromes, all ears and Maffucci. So these are the image representations of enchondromatosis syndromes. After the letter E in the mnemonic of Fechno-Machick, we have G, right? So G is for giant cell tumor and geode. So the first image here is representing giant cell tumor. Giant cell tumor is an epiphyseal tumor, as all of us know, and it usually is a expansile lytic lesion, epiphyseal in origin, and it breaches the growth plate, and it has an intra-articular extension. The distal end of the radius is the classical location where this giant cell tumor occurs. The second image is showing geode, that is subchondral cyst. Usually this is associated with conditions of arthritis, osteoarthritis or rheumatoid arthritis. In the inflammatory conditions also we can see this subchondral lucences, which are called as geodes. So now we are done with F, E and G. Let us go to the letter N. Letter N is for non-ossifying fibroma. So the second image in this is representing a lucent lesion which is eccentrically located and is having a sclerotic rim. So all these terminologies you have to remember. Eccentric lesion with a sclerotic rim which is located in the diaphyseal region is non-ossifying fibroma. And the first image is representing fibrocortical defect. So in the mnemonic Fechno-Machick, the first letter F is representing fibrous dysplasia as well as fibrocortical defect, right? So fibrous dysplasia is Shepherd-Crookes deformity that side, and fibrocortical defect is in close relation to the NOF, because the only variation between these two is size criteria. Whenever the lesion is smaller, that is less than 2 to 3 centimeter, we call it as fibrocortical defect. When the lesion is more than 2 to 3 centimeter, larger lesions of FCD is nothing but NOF. Now the terminology of FCD is not frequently used. We use non-ossifying fibroma whenever there is a sclerotic lucent region in the eccentric location. Now we are moving on to the letter O. O is for osteoblastoma. Whenever there is a lucent lesion in the posterior vertebral elements, we should have two differentials. One is osteoblastoma and the other one is ABC, aneurysmal bone cyst. So whenever osteoblastoma is less than 2 centimeter size, we call it as osteoblastoma. When it grows in size to greater than 2 centimeter, we call it as osteoblastoma. But for this location, you have to have another differential in mind, which is ABC, aneurysmal bone cyst. And then F, E, G and O is done, right? Now we are moving on to M. M is for metastasis and multiple myeloma. So the first one, the skull X-ray lateral view, is showing multiple lytic lesions, that is raindrop appearance of the skull seen in multiple myeloma. Whenever we are looking for multiple myeloma, it is important to see the mandible also. The lytic lesions are seen in mandible also. And then that is the spine showing multiple metastasis, lytic metastasis. This image we have ABC, which is metaphyseal in location. We have fluid levels in aneurysmal bone cyst. It is also an expansile lesion like the GCT, but GCT occurs in the epiphysis, whereas ABC occurs in the metaphysis. That is the differential point. The second image is about simple bone cyst or unicameral bone cyst. The arrow is pointing towards the fallen fragment sign. So whenever there is simple bone cyst, a fracture fragment falls into the fluid of the cyst. That is fallen fragment sign, which is pathognomic for simple bone cyst, and the usual locations for both of these are humerus. Aneurysmal bone cyst, as already told, posterior vertebral element should also be kept in mind. Then coming to H. H is for hyperparathyroidism. Hyperparathyroidism, we see a lucent lesion usually in the short bones, which is called as Brown's tumors. Brown tumor should be suspected when we see a lucent lesion only when other signs of hyperparathyroidism are there. So I have made a video on hyperparathyroidism signs in a video called distal clavicular erosions. So hyperparathyroidism is one of the differential diagnoses whenever you see distal clavicular erosions. In this, we should see another signs like rugged jersey spine and subperiosteal desorption of the bones, mostly on the radial aspect also. So for the distal clavicular erosions, I have made a video in which hyperparathyroidism signs are clearly demonstrated with the help of images. Now we are done with H. Let us move on to the letter of I. So I, you have three differentials. One is infection, the second one is infarction, and the third one is intraosseous lipoma. So the first image here is representing infection, and the second one is representing multiple lytic lesions there, indicating infarction, and the third one is showing the calcaneum bone with intraosseous lipoma. Now let us dwell into each of the image. So the first one is showing a lucent lesion with a thin sclerotic rim in the proximal end of the tibia, which is representing Brodys abscess infection osteomyelitis. Second image is showing multiple lytic lesions in the distal end of the femur and proximal end of the tibia. There we can also see associated fracture in the fibula, proximal fibula. The third image is showing intraosseous lipoma in the calcaneum. There is a famous sign called cockade sign to remember this intraosseous lipoma. So this sign is called cockade sign, and intraosseous lipomas are common in calcaneum, and for the calcaneum also the most common lesion is intraosseous lipoma. Now we are left with the last letter, that is C. C is for chondroblastoma and chondromyxoid fibroma. So the first one, chondroblastoma, is an epiphyseal tumor. So similar to GCT, chondroblastoma is also a epiphyseal tumor. Lucent lesion in the proximal end of the tibia, epiphyseal in origin. So two epiphyseal lesions, one is GCT and the other one is chondroblastoma. The GCT, we have seen there will be multiple expansile lytic appearance in the distal end of the radius, epiphyseal location GCT, and here it is in the proximal end of the tibia, lucent lesion, chondroblastoma. The last one, which is chondromyxoid fibroma, usually it is metaphyseal in location, and it is also having a lucent appearance and eccentrical location. So this summarizes the chondromyxoid fibroma as well, and the lucent or lytic lesions of the bones for you. So this one image is having all the examples along with their typical appearances and the classical morphological features and the location, epi, meta, diaphyseal, or which bones are more common, everything summarized in this video. After understanding the appearances of all these lesions on X-ray, CT, and their important locations, let us see this table which is giving some information to us. Fibrous dysplasia will not have any periosteal reaction, and when we talk about this eosinophilic granuloma, less than 30 year is an important point, because there we are seeing physis, that is growth plate, it's not still fused. It is less than 30 years of age group is a mandatory criteria to diagnose eosinophilic granuloma. For enchondromas, we have seen through two syndromes, Olliers and McPhusey's. And giant cell tumor, it is epiphyseal in location and it has a non-sclerotic margin. For NOF and FCD, we have seen sclerotic margin, but here it is non-sclerotic margins. It is epiphyseal in location and the epiphysis is closed. For eosinophilic granuloma, it's not closed and it's less than 30. And then for N, it is NOF and FCD. Size criteria matters for both. And osteoblastoma, usual location is spine, that too in the posterior elements. The differential diagnosis for osteoblastoma is ABC, as already described. And then M is for multiple myeloma, age should be more than 40. A is for aneurysmal bone cyst, expansile lesion, simple bone cyst is centrally located, and fallen fragment sign is seen. Then coming to H is hyperparathyroidism, Brown syndrome. Other signs are very much important as told. And I is for 3, that is infection, infarction, and intraosseous lipoma. Watch the video on the Radiology in Nutshell channel on YouTube for hyperparathyroidism signs in radiology. I is for infection, infarction, and intraosseous lipoma, right? So in the infection, we have seen Brodys abscess, infarction, we have seen multiple lesions in distal femur proximal tibia, and intraosseous lipoma is cockade sign. Chondroblastoma, E is for epiphyseal origin, and chondromyxoid fibroma. Whenever you are mentioning the term non-ossifying fibroma, other differential that should be kept in mind is chondromyxoid fibroma. So this summarizes the lytic lucent lesions of the bone, which is a very much importantly tested topic in all the radiology exams. It can even come for the long case also, and spotters also. These bone lesions are frequently asked. When we know this mnemonic and when we know these appearances, it's almost easily answerable. Most of the questions we can answer. If you like the content of the video, please do like, share and subscribe to Radiology in Nutshell channel on YouTube, and this is the Telegram channel QR code. There is a lot of effort that I have put to make this video, so please do subscribe. Thank you.